Very good evening to everybody, and welcome to this series of ICU webinars that we're conducting on behalf of the ICS. This is under the leadership of Dr. Sandeep Salve, Dr. Rajadhar, and of course being spearheaded by our own dear Dr. Amita Nene, the main force and spirit behind all this. It's indeed a great pleasure for me to be having this, the galaxy of stars that we've collected this evening for this evening's webinar. This evening's webinar is a little different from the usual ones. Usual are more about diseases, illnesses. Today, we're talking about mechanical ventilation and the graphics, which is a little more mechanical, I would say, a little more arithmetical, algorithmical is what I would call it. So mechanical ventilation is now being used as a therapeutic modality in the ICUs and across the ICUs. We all must have a thorough understanding of how we are ventilating our patients, of the different ventilators, their functions, and also their alarms. The conventional ventilators that we use these days, they provide evaluation for the respiratory mechanics through the graphics. These graphics or the waveforms are displayed very well on the ventilators, and they give you a fair idea of the lung mechanics, the compliance, the lung functions. So what a pulmonary function test does for a non-ventilated patient, these graphics provide you a similar kind of an information about the lung mechanics in intubated and mechanically ventilated patient. Therefore, it is very, very important for all of us to understand these graphics and to be able to interpret how to, into clinical applicability of the waveforms and the loops that we see. And to discuss with us all these graphics and all, we have none other than Dr. Khusrao Bhajan with us. He's the HOD of Emergency Medicine, Critical Care Consultant, PD Hinduja Hospital and MRC. He's a gold medalist in the first certificate course held by ICCM in 1999, first to bring the AHA, BLS and ACLS courses to India in 2000, chief of the relief team for Bhuj earthquake victims in 2001. I was also a part of not this team, but a separate team that we'd gone from our own hospital at that time. Recipient of the Lifetime Achievement Award for Emergency Medicine in India in 2015, Fellowship of College of Critical Care Medicine in India, co-author of books like Textbook of Emergency and Trauma Care and Textbook on Signs and Symptoms in Clinical Practice, and so many other accolades that he has received in this span of his professional career. I'd like to hand over the dais to Dr. Khusrao Bhajan to take this forwards and tell us about the graphics and the loops that we see on the ventilator of the patients with various kinds of illnesses in the ICU. Dr. Bhajan.
Yeah, thank you, Dr. Vivek, for that amazing prelude towards the topic. And I thank Dr. Amita Nene and the entire Chess Society for having me here to discuss the ventilator graphics. It's sometimes you are very familiar with it and sometimes you're not. So if I can share my slides, I'll just start without much ado. Yep. So I'm going to take you through in the next 20-25 minutes on the ventilator graphics and how useful they can be. And then we look forward to an amazing discussion moderated by Dr. Vivek on troubleshooting on a ventilator, especially the patient's problems and conditions. So let's move on. Just some thoughts to start off, which I keep pondering on. Is ventilator graphics just one more screen in a multimodal ICU? Why was I not invited to Ayodhya, or rather did I want to be invited? Why are physicians so underpaid? Will I be jobless due to AI? And will this talk be obsolete soon due to the AI integrated ventilator graphics? So before that, let's learn the graphics before AI takes over. Often we look at the ventilator and we take it as a problem that many patients feel that once you are on a ventilator, it's a one-way ticket to heaven, but that's not true. But we must, as doctors, remember that ventilation is not a treatment and it is only a modality of support, and therefore we must make sure that we do no harm. Educators take something simple and make it complicated, and communicators take something complicated and make it simple. And I am only a mere clinician who is going to try and make this a simple topic. Many a times we wonder whether the patient is on the ventilator or patient is under the ventilator, and we should understand that we are connecting the ventilator only for a certain period of time till the lungs actually recover. So we must not do harm, and we must be extremely gentle with the patient's lungs. So ventilator graphics during mechanical ventilation helps us to determine not only the modes of mechanical ventilation, the TLC, which is not tender loving care, which we should do for all our patients, but it's the trigger, limit, and cycling. Understand the lung mechanics, problems and troubleshooting, synchrony and asynchrony. And it also helps us to adjust a lot of alarms and ventilator settings in a given patient. So why do we need ventilator graphics? Yes, it tells us the modes, the TLC, auto PEEP, trigger, work of breathing, the upper and lower inflection points, the resistance, compliance, leaks, secretions, hysteresis, and even the asynchrony of the patient and the ventilator whilst it is on. So much I need to cover with the use of graphics alone in the next 20 minutes or so. So I might go a little fast, but the moderator could stop me and ask me to explain if it's not very clear. So let's deep dive into ventilator graphics. We would divide the ventilator graphics or the waveforms into two main types. One is the scalars and one is the loops. So scalars are waveforms when pressure, flow, or volume on the y-axis is plotted against time as the x-axis. Whereas loops are only two, that is the pressure versus volume or flow versus volume. And this is what I will just try and show you. The scalars and the loops look like these. And there are only 5 things that we are going to look at. We are going to look at pressure on time, flow on time, volume on time, and the loops would be flow with volume and pressure with volume. So these are the only 5 things that would actually help us in determining everything that I mentioned earlier. So what are the scalars? Let's do the scalars first and then the loops. So there is a 6-step approach to the ventilator graphics, but I don't always believe in these steps. You can do everything together in a horizontal fashion. First, you need to try to know what kind of a mode it is, the type of breath, volume or pressure, differentiate compliance from resistance, know the lung mechanics, the pressure volume loops and the flow volume loops help us to interpret the expiratory waveforms, etc., and the modes and the asynchrony. So first things first, what is the type of breath? When it is a mandatory breath, you can see pressure against time and it starts from a 0 point or the PEEP point, and that would be an inspiration and an expiration or an exhalation. If it is an assisted breath, it has to be triggered by the patient, and therefore whenever you see something negative here, this is a trigger by the patient. A trigger on a ventilator could be only pressure trigger or it could be even flow trigger. And these are the 2 triggers on a patient. So this means that the patient has made an effort and now the ventilator is giving the breath or supporting the breath or assisting the breath rather. That's the right word. And spontaneous ventilation or breathing would be an inspiration is negative pressure here because it is spontaneous, and expiration would be on the upper axis. So this is how we understand what breath the patient is taking. The scalar forms can be divided into pressure on time, volume on time, and flow on time. And these get a little bit difficult to understand because you can have rectangular, exponential, sinusoidal, ascending ramp, descending ramp. I would just tell you to remember 2 or 3 things. One is rectangular, one is sinusoidal, and one would be a descending ramp. If you can remember just these 3, we can understand scalars very well. So this is probably the most important introductory slide on understanding the modes and the scalars. If we understand that, we can understand a lot of other problems with it. So here in this patient, the patient is on a volume controlled mode. The lung is like a balloon. You need to blow in air, fill it up with a certain amount of volume, for which you will need a certain amount of pressure, and the flow will be decided between the dynamics. So when you have a volume controlled, you are targeting a volume. So you say 500 ml should go in, and therefore once that volume is reached, there will be a blunting and a scalar. So there will be a volume curve like this in volume control, but the pressure is uncontrolled and we have no control over the pressure here because we are not setting it. So depending upon type of the balloon or the lung, whether it is compliant, whether it is got a lot of resistance, this pressure graph will go up and up. And then there is a plateau, which is an inspiratory pressure. And then you will have an exhalation. And when you look at the flow is constant in these patients because after a certain volume has reached and the maximum pressure, the peak pressure has reached, the flow will not increase or decrease, and therefore it is like this. So please make sure that on a volume control, you will have these three types of graphs. As against that, in pressure control, we are actually monitoring the pressure and we are targeting the pressure, limiting the pressure. So the pressure will be a flat line. Once that 30 millimeters mercury of pressure, 20 millimeters is reached, then the pressure will not increase. So what will compromise depending upon the lung mechanics? The volume might compromise, and that could be a flatter graph if the patient has decreased compliance or resistance, increased resistance. And the flow in pressure control is always decelerating. Now, this decelerating flow is supposed to help open up the alveoli with long time constants, and therefore this might be a good mode in ARDS. So if I can move on in volume control again, we need to understand what is the trigger, the limit, and cycling. So taking the same slide forward, in volume control, which we mentioned here, you can also think about calling it a flow limited. So it's limited by flow and it is volume cycled. The amount of 500 ml or 400 which you have set, once it is reached, then the inspiration cycles to expiration. As against that, in pressure control, it is called as a pressure limited, as you can see the flat graph here, and it is time cycled if the patient doesn't make any breaths. So depending upon your I ratio and your respiratory rate, it will be time cycle. So we need to understand volume control is flow limited, volume cycled. Pressure controlled is pressure limited, time cycled. If you still don't understand this, absolutely okay, because I also flutter sometimes and fumble on this. But remember that these graphics at least tell you which modes you are on. So again, these are the two modes, but there is a little difference between the pressure control and the pressure support mode. And here we have, I'm just depicting what I mentioned. But when somebody or the patient starts taking a breath with a negative deflection, then you have a pressure support mode. And here the difference between pressure control and pressure support is nothing else but the cycling. So the cycling here in pressure limited happens when the time is reached and between breaths, and it will be time cycled. Whereas in a pressure supported mode, when the flow reaches 25% of the peak flow, then it cycles to expiration. And this is set on the ventilator. So this is pressure limited, flow cycled. I'm very sorry if I've confused you all, but this is pretty understandable. And the three graphs that we need to know in volume control, I'm going over it again. Pressure has no control and therefore it may rise, and it will be flow limited. Flow is flat. In pressure limited, you would have a pressure which is limiting it and time which is cycling it. And in pressure support, it is pressure again limiting it, but it is the flow. When it reaches 25% of expiratory flow rate, it starts cycling into expiration. And this is a graph showing the same thing. Now, when you look at this graph, where it is flow against the time, and you see that this is end expiration and this is not reaching the baseline, it means that there is air trapping. So because of air trapping, which we might see in auto-PEEP due to a COPD or an asthmatic or sometimes dynamic hyperinflation, this peak pressure, expiratory pressure should be looked at and whether it is reaching the baseline or not. If it is not reaching the baseline, that means there is an auto-PEEP. So just by looking at this, first thing can be diagnosed. Now, if I have a patient with a respiratory rate of 20, this is the normal kind of breath where the end expiration happens properly and the new breath starts. But as you can see in the B line, here the end expiration also reduces. There is a little scaffolding, and then it does not reach the baseline, and that means the next breath is starting a little earlier and not allowing the lungs to empty. So what can you do when you see a graph like this? You reduce the rate and you prolong the expiratory time by doing so, and you allow the auto PEEP to reduce to 0, and you can see that just by reducing the rate you have helped this patient. Now, looking at the lung mechanics, we need to understand again, as I mentioned earlier, there are only three mechanics. One is pressure, one is flow, and one is volume, and all these are related with time. So when you have a flow through the airways, and then you have a tidal volume which fills up the lung and under a certain pressure, therefore this resistance is calculated. The resistance of the entire airways is calculated by the trans airway pressure upon the flow. As against that, compliance is nothing but a volume upon the pressure. Sorry for so much maths, as Vivek rightly said, it is all mathematics, but I will just try and make it as simple as I can. Looking at this graph again, this is the peak inspiratory pressure, this is the plateau pressure, which is the inspiratory hold pressure, and if you go further, you will actually look at this as the transalveolar airway pressure, and here this is the transthoracic or the alveolar pressure. So this B actually tells you how much is the pressure in the alveoli, whereas this tells you the entire trans airway pressure above it. I have a small mnemonic because I know we are all confused already and there's lots to go, but a compliance is equal to volume upon pressure and resistance is equal to pressure upon flow. Now, how do I remember this? We all in the intensive care and in pulmonology know the CVP. So you can remember C is equal to V and P. And for resistance, I could not get a better mnemonic. So I said it could be a retired provident fund. You may want to remember it that way. And this is what compliance and resistance is calculated. Now, how it is calculated. And nowadays, the ventilators actually calculate it for you and give you a compliance and resistance. And this is how you will see the graph. The peak pressure will tell you the distance between that is going to be. So you may have a peak pressure and you will have a plateau pressure. And this is going to be discussed at length. So I won't go into details. But just for the sake of graphics, if there is a high peak pressure and the plateau pressure is also high, that means there is a compliance problem like here. And if the peak pressure is high, but the plateau pressure is normal, then it is a resistance problem. And then there will be lots of mechanisms for each, which again, I will wait for an amazing discussion and hear it from the panelists. There is one more thing that we talk about on ventilating ARDS, and that is the driving pressure, which is nothing but here we have the peak, here we have the plateau, and here we have the PEEP. So driving pressure is nothing but the plateau minus the PEEP. And at all times, we need to keep this at about less than 15. And then there is one more graph here where you can see that this line goes above, and that is the auto PEEP and the set PEEP. So that gives you a total PEEP. Stress index can actually, I wouldn't go into details, but it can tell you tidal recruitment versus over distension. And now the most important part on the scalar is the asynchrony before I move on to the patient understanding of our loops. So in asynchrony, there are three types of asynchronies between the patient and the ventilator. And 99% of the times, this asynchrony does not happen because the patient is agitated, but because we allow him or her to get agitated because of our wrong settings and wrong modes. So the trigger asynchrony is an ineffective triggering or a reverse triggering or a double triggering or an auto triggering. And these are the graphs which will tell you. I'm not going to go into details. I'm only going to make you aware what a graphic can do. In the flow asynchrony, you have insufficient flow and you have overshooting. And in the cyclic asynchrony, the three types of asynchrony, here you have a premature one and here you have a delayed one. I wish they had better terminology here. So this is showing you the same thing. You see an ineffective trigger, the patient triggers but doesn't get a breath. And then there is double triggering and the patient still doesn't get a breath. Yeah. I'm missing some slides. Okay, so when you see a starvation or a flow asynchrony, then you would have an indentation here, and that also says that you might want to give a higher tidal volume or a higher inspiration flow rate. Okay, let's move on to loops now. But before that, I will just say that even the ventilator-associated lung injury in terms of asynchrony can be divided into barotrauma, volutrauma because of the asynchrony, but also myotrauma, and it can affect the diaphragm, and the recovery of the diaphragm takes ages, and then the patient gets bound to the ventilator. And there is ergotrauma because of the energy delivery, and therefore they are now talking about the mechanical power. Let's move on to the loops. And the loops basically are important because it tells us a lot. So first, let's look at the flow volume loop. And in this is the inspiration, this is the expiration, this is the FRC, this is the tidal volume, and this is the peak expiratory flow rate. Now, on a ventilator, we would have it in this form. We would have this as an inspiration, this is an expiration, and you would see that in the expiration, this should have been normal as in the dotted line, but here you have the end expiratory flow less, and you have a scooping here, and this is nothing but an increased resistance caused to the patient, and this is expiratory resistance. Same thing you can see, and you can do a bronchodilation, and before and after you can see the changes that have happened. There is worsening, and it's much better after giving the patient a bronchodilator. So scooping and reduced peak expiratory flow would indicate an increased expiratory resistance. If you see a graph, this is normal, and if you see a graph which instead of ending here and meeting the inspiratory beginning, it ends here, that means there is air trapping again, as we saw on the scalar form. And this is again depicting the same. So if it empties here, it just means that there is auto peep and it cannot reach the baseline. So whenever a graph does not reach the baseline, it means there is air trapping. Now looking at this waveform, again you can see that there is a scooping here during the waveform and a scooping here during the scalar. And this is nothing but asynchrony, inadequate flow, and flow starvation. When you see a graph like this, wavery, like a carpenter's knife, then it means that there are plenty of secretions, and if you don't suction the patient, there can be a mucus plug in this patient. Now coming to the PV loops, and I assure you, this will be a little more interesting than the previous. In this, we plot a volume against the pressure. We call it PV, but you can call it anything. So it's volume against pressure. Here is the inspiration. This is the expiration. This is a line linear between it. You have the peak inspiratory flow at this point, pressure at this point, and you have the tidal volume at this point. And this point would be your compliance. How much pressure is needed to give the same amount of volume? So C, V, P, if you remember C, V, and P. Now there is another term called as hysteresis, which is the distance between these two arms. And the normal hysteresis is shown in this, and the abnormal one is in the yellow. So the abnormal one means it has become fatter, and we look into this and tell you why this happens. So the work of breathing can be actually calculated in this form, and you have A, which is the resistive work, and B, which is the elastic work. You can forget this. And in this, again, you have inspiration and expiration. I've just tried to give more graphics to make you understand. I hope I'm not complicating it. And here, these are the two most important things. The fatter the loop. Now you have this loop. If the loop becomes more and more fat, the higher the resistance. And you can also tell that is it inspiratory resistance if this becomes bigger, or is it expiratory resistance if it becomes fatter here. So basically a fatter loop is increased airway resistance, and more vertical it means the compliance is good. So if this graph goes more on the volume side, means the compliance is good. And if the volume side goes down and it becomes flatter, it means low lung compliance. So this is very, very easy to understand the hysteresis and the volume pressure curve. Again, I'm trying to show you the same. but we'll move on and I'll explain it a little better. So this is more flatter and you are getting less volume for an increased amount of pressure. So I cannot ask you questions on Zoom, but this is nothing but anybody? Yeah. Decreased compliance, which could be because of ARDS or fibrosis. And here you can see that it's becoming more and more vertical. So you're getting more tidal volume for lesser pressures. And this is nothing but an increased compliance, which may be seen with COPD or emphysema. Again, I mentioned this hysteresis. If this balloons up, it's inspiratory. If this balloons up, it is expiratory airway resistance. And this will actually tell you a lot more. I've kept more and more diagrams so that we get confused initially and then understand the entire thing. This hysteresis is taken by one more step further and it gives you 2 points. One is the lower inflection point and the upper inflection point. Lower inflection point is basically for an increasing pressure, the volume does not increase much, but after that, it increases exponentially. And the upper inflection point is that point where now even further, if you increase the pressure, the volume is not going to increase much. And that is called as the upper inflection. So at the lower inflection and below, you are going to have atelectasis. And at the upper inflection and above, you're going to have over distension. So on one hand, you want to prevent over distension. On the other hand, you want to prevent atelectasis and therefore always stay in the safe zone. And we will look into this in a bit. So basically, when you see a lower inflection point, what we need to do is we increase the PEEP and improve the FRC so that the atelectasis can be prevented, And in the upper inflection point, if there is a beaking, if you can see this becomes a beak, then we decrease the plateau pressure and we decrease the tidal volume, which in turn will reduce the plateau pressure. So this is how we can look at the graphics and try to understand. And as you can see here, because of the beaking, there's over distension, and here there is atelectasis and the alveoli are not getting recruited, which can be shown even on the basis of a CT scan. Now, when you see a loop like this, volume against pressure, and it doesn't empty or doesn't end equally well, then it is nothing but a leak in the circuit, and we need to look into this immediately. When you see this inspiration and expiration, and this looks like a fishtail, that means there is increase in the work of breathing. Patient is making a lot of efforts, and therefore it indirectly means there is asynchrony and increased work of breathing. So we need to address this. There are many other modes. If you use APRV, it looks like this. High frequency oscillation, it looks like this. And on the graph of hysteresis, you can see APRV in the safe zone here and HFOV in the safe zone here, but we are not going to details of that. So in short, I'm done here, but a ventilating graphics in summary helps us not only to understand the trigger limit cycling, the modes that their patient is on, the lung mechanics, the resistance, the compliance, etc., troubleshooting problems, which I'm desperately looking forward to with Vivek to do an amazing moderation and the panelists, help patient ventilator synchrony, give us a real-time feedback of the modes and the lungs, prevent the ventilator-associated or induced lung injury, and also it can help me in weaning the patient. So there is lots of excitement and lots of things to look at. But if you are sure you understood everything that is going on or which I spoke, you are hopelessly confused, because I would have been confused if I had to listen to this lecture. And you all are looking at me now like this. Thankfully, for the Zoom, I can't make out who's looking at me this way. Do nothing, see nothing, hear nothing. But I would quote Albert Einstein, who said, making everything as simple as possible is good, but not simpler than it should be. So keep calm and close the loop, my friends. And that's what I have to say.
Thank you, Kushna, for an amazing, amazing talk. Of course, we can't do that on a webinar like this, but certainly we would have given you a standing ovation for this. I mean, it isn't really a topic which is, one, very well discussed, two, made so simple as you've done that. I mean, such a complex topic and made so simple and so easy for anybody and everybody to understand. It's really amazing because, one thing is to see the graphics and understand them, and the other is to explain to the others. It takes a lot of guts to be doing that. So I'm really very, very happy. I'm impressed with your talk on this.
Thank you so much, Vivek, because I actually thought I'm trying to confuse everybody. It's very, very difficult on the first time. Maybe you have to play with the ventilator, look at the graphics every day. Only then would you probably understand what we spoke today. Thanks, Vivek.
Yeah, absolutely. You're absolutely right. This is something that you need to be doing on a regular basis to be able to understand this. Otherwise, it's very, very difficult to understand. Okay, now, so we move on to our panel discussion now. And let me assure you guys, you've heard a brilliant talk by Khushrao Bhajan. And now we have an even more brilliant panel discussion where Khushrao is with us, along with 4 other panelists who I'm going to introduce to you all. So the first panelist, I hope you're able to see my slides. Okay. So the first panelist, we have Dr. Tampi, who's, sorry, just give me a minute. Dr. P. Shamsundar Tampi, he's basically a senior consultant pulmonologist and physician at Bombay Hospital and Medical Research, and has years and years of experience of not just practicing, but also teaching. He's a DNB teacher and examiner, president-elect of the Western Indian chapter of the American College of Chest Physicians, president of the A-Ward Medical Association, Mumbai, governing council member of IAB, and so many other associations. He has numerous publications to his credit. I'm sure innumerable presentations and several awards, including the Rajnanda Pulmonary Disease Research Fellowship that is very coveted and much desired by so many pulmonologists across the country. Next, we have Dr. Komal Shah. She is a DNB pulmonology and a gold medalist of that from Jaslok Hospital and Research Center in 2013. She's one of the few pulmonologists in the country with interests in infectious diseases and has done a fellowship in infectious disease from CMC Vellore 2022, and currently is working as an associate professor at the Dr. Vasantrao Pawar Medical College in Nasik. Then we have Dr. Neeraj Gupta, who's the senior professor and medical superintendent at the JLN Medical College and associate group of hospitals in Ajmer. And a secretary of state chapter of the Indian Chest Society and chairman of the West Zone ICS. Again, somebody who's very talented, very well read, very well representing himself in most of the conferences, and we've heard him so many times. Very impressive. It'll be a pleasure to have him with us this evening again. And then we have Dr. Shrema, who's DM Pulmonary Critical Care from AIIMS in New Delhi, one of the most prestigious institutions of our country, and is currently working as an assistant consultant pulmonology at the PSG Coimbatore. The areas of interest include critical care, ARDS, mechanical ventilation. She has authored chapters on ARDS management at such a young age, and also on the management of refractory hypoxia in the clinical key, which is again very prestigious to be associated with. She has published the first prospective study on awake-prone ventilation of COVID-19 patients from India. COVID-19 we've all faced, but this paper I'm sure will be worth reading. So with this, we will now open up our panel discussion. Let me just close this down first. Okay, guys. So basically, you've heard Dr. Khushrao Bhajan tell us about the ventilator and the graphics. But what is important is the troubleshooting. Our panel discussion this evening is going to focus on troubleshooting when you hear the various alarms. So what do you do when you hear the alarms? Do you just silent the alarms, or do you take some action? Is the question that we're going to be discussing. So many other questions. All the alarms. There are a plethora of alarms on the ventilator. This is important because when a problem occurs, it can cause the patient to experience discomfort and even put their lives at risk. So the goal of ventilator troubleshooting is to quickly identify the problem and then take the necessary steps. So, there is something that should be coming from within you, like a spontaneous reaction. When you see a particular alarm, you should, again, as I said in the beginning, it's like algorithmical. Go from the algorithm that 1, 2, 3, 4, 5. Have you done this? Have you checked this? Like a checklist that you would do. So in a perfect world, the delivery of mechanical ventilatory support would be flawless and we would never experience any problem. However, this usually does not happen. So there are various problems that occur during the mechanical ventilation. So let me start with asking Dr. Tumpy the first question, that what are the various ventilator related problems that can occur with a patient who's on the ventilator?
Thank you. Good evening to all. And we also like to thank ICS and Dr. Amita in particular for giving us this opportunity to participate in this very, very important webinar. So the question is, what are the various ventilation-related problems that can occur? Now, I will not talk about the patient-related issues. I'll talk about the ventilator-related issues, and there are several of them. For example, to start with, you can have the ventilator in-op alarm going off. So what do? So you need to switch off the ventilator and try and restart it. Well, if it does not operate properly, it is better to replace the ventilator. Then the problem of power failure can happen. Many times the plug may get detached from the electrical point, and one must immediately re-plug it in and assure that the power cord is plugged in properly to an electrical outlet. If the battery is low, then it is better to, the internal or external battery is low, it's better to connect it directly to the electrical outlet. And of course, one can check the fuse or the circuit breakers further, and you'll probably need technical support for all that. However, if there's no gas delivery to the patient, now ensure that all high-pressure gas hoses are tightly connected to the appropriate gas sources. Check the oxygen and air pressure. The gas pressure gauge is located at the gas shutoff valve. Check the cylinder tank gauges if using gas cylinders. And then you have the very common problem that we all face is low pressures, such as low peak inspiratory pressures, low tidal volumes, low minute ventilation, low PEEP and CPAPs. Now, what you need to do is check the circuit for leaks or disconnections. Tighten or reconnect the connections. And of course, check the patient's airway cuff for leaks or deflation. Check the humidifier for leaks or disconnections and tighten or reconnect the connections. Check the inline suction system for leaks or disconnections. Check the inline adapters for metered dose inhalers or small volume nebulizers. And check for chest tube leaks if the patient has a chest tube. And then reset the ventilator settings and alarms and make sure that they are working properly. So these are some of the lower pressure ones, due to leaks. What happens if the patient, that the apnea alarm goes off? So immediately assess the patient's breathing. If the patient is apneic, begin manual ventilation with an AMBU bag. Assess the patient's clinical condition for causes of apnea and contact the patient's, get the causes sorted out. If necessary, correct the clinical problem first. And that should be the thing. Check the ventilator's sensitivity setting to ensure that it detects the patient's inspiratory efforts. Then the I ratio alarm, it usually indicates an inverse ratio, and therefore one must ensure that the flow rate is set appropriately. Then comes the problem of high minute ventilations, high pressure limits, high respiratory rate, and high FiO2. All these can also happen. And assess the patient for respiratory distress. That's what you should do when you have a high minute ventilation. And particularly high pressure. Assess the patient for respiratory distress. Check for an obstruction. The tube may be kinked, or reposition it to straighten it. Sometimes the patient bites the tube, considering place an oral airway or a bite block. If the tip of the artificial airway is impinged on the tracheal wall, reposition the tube to free the obstruction. For all other obstructions, attempt to clear the tube with a suction catheter. If unable to clear the tube with a suction catheter, then it is better to replace the inner cannula of the tracheostomy tube, remove the artificial airway.
We'll come to each of these problems individually.
Yeah. Okay. Basically, I wanted to sum up the issues of low pressure due to a leak and a high pressure. And I'm sure that we'll be discussing many of these in greater detail.
We shall discuss this subsequently. Yeah. So I think broadly, if you look at it, the various ventilator-related problems that can occur are ventilator alarms, leaks, circuit disconnection. You have to start right from checking the power outlet, whether that is functioning or not functioning. And sometimes, what we do is take the patient onto an AMBU and shift the ventilator onto a test lung and see whether the ventilator is functioning appropriately or not. But, despite that, sometimes it happens that the patient, when you go in the morning rounds, the patient is breathing faster than the ventilator is delivering.
We lost you, Vivek. He's logged out, so I think he's logging in again. Give us some. How do you use time constant during use of ventilation? So time constant actually is dependent upon the alveoli will have long time constants. So you need to use a decelerating flow and pressure control to try and open them up and keep your inspiratory cycling at its optimum. Next is COPD, ILD, differential on ventilating graphics. So we are only looking at what I showed you. You cannot be diagnosing the condition of the patient on this, but you would definitely in COPD, because there is an increased compliance, you will see a graph which moves. The PV loop will move more vertical on the graph, whereas ILD will be restrictive, so there will be an increase in the pressure. What? Is sigh breathing useful? So sigh breathing was used very, very many years ago. And we also naturally take a deep sigh at times, which opens up our alveoli. So this sigh breathing is kind of a controversial topic, but it's coming up again. And it's nothing but giving big breaths, trying to do a semi-recruitment maneuver. I think, yeah, Vivek, we had lost you. Audio, you're mute. Yeah, perfect.
Technical glitch. I'm back now. So, Dr. Seema, I was asking you that what is about the ventilator patient dysynchrony? What are the various causes and what do you think about it?
Right. So at the outset, thank you for making me a part of this webinar. Thank you for to the ICS organizations and also to Dr. Amita for inviting me. So coming to the question here, so ventilator dysynchrony. So basically, what we attempt to do is match the patient's demand with the ventilator. So that is when we have total synchrony. But patient ventilator dysynchrony is a very frequent problem. And when we come to any issues with the ventilator, I like to think it like a continuum, like you start with the patient, then the circuit and the ventilator. So causes of dysynchrony can happen anywhere. So the first thing with the patient is when there is an increased ventilatory drive, which could be part of the disease process. Like if the patient is in sepsis or the patient has fever, pain, anxiety. So all this can increase the ventilatory drive and hence the patient would demand more from the ventilator. So the second thing is coming to the circuit. So if the circuit has any leak somewhere or any blockages, so there can be issues with the circuit. So most of the time what happens is we look at the patient and we look at the ventilator and we forget about the thing in between, that is the circuit. And a lot of times the things in the circuit, which includes the humidifier, the expiratory valves, we sort of tend to overlook these things. So if we think it as a continuum, it's more easier to find out. And of course, the third thing is the ventilator settings, which can be, like we already discussed in the presentation, problems with the trigger, problems with the inspiratory flow, and problems with the cycling. So to diagnose dysynchrony, if it is an extreme dysynchrony, it's pretty easy. The patient will be fighting the ventilator. There will be tachycardia, diaphoresis. Patient will be using accessory muscles. So the point of ventilation is to give comfort to the patient's breathing. when you intubate a patient. So basically, if a patient is having a lot of accessory muscle use, then that is also a marker of a ventilator dysynchrony. But most of the times, the dysynchronies are quite subtle, and you would see them on the ventilator, and you would just see that the patient's respiratory rate is a little high, and so that's why we have to be very carefully looking at the monitor every day when we take rounds. So look at the patient and then also look at the ventilator screen. So other than the accessory muscle use and work of breathing, we should also check for the other things like auscultate for wheeze. And if you always stand near the patient, you can sometimes even hear the cuff leak. So all these things are so overall, to diagnose it, you need a clinical thing on the patient as well as being able to interpret the ventilator screen. So that is also quite important.
Right. So, Dr. Seema, you've highlighted very well the common, how the patient would be presenting when they have a dysynchrony. But I'd like Dr. Neeraj to once, give us a summary of all the possible signs and symptoms that would be seen in a patient when there's a ventilator mismatch. Dr.
Yeah.
Neeraj?
First of all, my sincere thanks to the ICS for giving me chance to speak on this forum. Actually, when we are on rounds and the patient is in ICU and on ventilator, we should look on the patient's faces, his appearances also along with the screen of the ventilator. So when the patient is in respiratory distress, patient is fighting with ventilator, is anxious, there is tachypnea, there is use of accessory muscles, there is asynchrony between thoracic cage and the abdominal wall, there is tachycardia, there is hypotension, there are arrhythmias. So all these findings, physical findings as well as the findings on the screen, they can suggest that yes, there is some problem between the patient and the ventilator, and we should sort out the cause, what can be the possible cause, and we should have an idea of the patient's problem. Hypoxemia, hypercapnia, high pressure, low pressure alarms, these are the actually indicators which can suggest that the patient is in asynchrony with the ventilator, and we should sort out the problem. Hypotension, very important.
Yeah. So pursed lip breathing, patient coughing, not being able to breathe properly, oxygenation dropping, all
Yes.
those are things that you need to look at. Use of accessory muscles, arrhythmias, dyspnea.
Yes.
So very good. So Dr. Komal, it may just sound like an MCQ kind of a question, but because before we go on any further, could you just enlist the various alarms, that you really look at when you go and take your rounds in the morning?
Sure, sir. First of all, thank you very much for giving me the opportunity to the ICS and also, of course, Dr. Amita Nene ma'am. So about the alarms, how I remember is like I divided it in 3 groups: pressure alarms, alarms related to respiratory rate, and alarms related to volume or minute ventilation. So there are high pressure alarms and low pressure alarms. So when there is high pressure alarm, obviously, as ma'am earlier mentioned, we have to see the circuit, the ventilator, and the patient. So high pressure alarms will be when there is some increase in the resistance or decrease in the compliance. So it could be either in the circuit, like when there is a thinking in the ventilator, or patient is biting the tube, or if there is a collection of endotracheal secretions, bronchospasm, or if extrathoracic like pneumothorax or collapse of the lung, or pleural effusion or anything can give rise to high pressure alarms. So normally the alarms limit that we set is around 35 to 40 centimeters of water. And if it is higher than that, we have to suspect the high pressure. Same way, when there is low pressure alarm, it means that there is some leak in the, or there is some breach in the continuation. So either there is disconnection of the ventilator, or there is cut in the circuit, or the patient must have been extubated by self, or there is anything, the cuff pressure is low. So then there will be low pressure alarm. Then we come to the rate related alarms. So when there is tachypnea or bradypnea, then there will be alarms. So again, if there is dysynchrony, if there are any pathological reasons for increased respiratory rate, there will be alarms. More important are the apnea alarms when there is disconnection of the ventilator. And third is the minute ventilation alarms. Again, we know that it is volume into rate. So when there will be high rate, there'll be high pressure alarms, which is around 12 to 15 ml. And more importantly, again, the low alarms when there is a low volume generated.
Very good. I think that was just the right way of highlighting all the alarms, that you have the pressure alarms and the volume alarms and the leak alarm, the apnea alarm, high PEEP, low PEEP. So, Dr. Tampi, when do you really find a leak in the system? How do you identify a leak? What are the causes? And then what do you do with the leak if you see?
Yeah.
Of course, Dr. Kushaw showed us a very good slide of the leak happening in the circuit in the
I know
graphic.
that was very informative and from the graphics. But mostly what happens is when there is a leak, there is a drop in the pressures and the low pressure alarm goes off. So that is one of the first things. And many causes are there, but however, partial or complete disconnection of the patient from the ventilators, probably the commonest cause. And bronchopleural fistula can be another cause. A leak in the system. Now, how do you identify whether the leak is in the system or it is in the tubing or in the airway? On manual ventilation, if resistance is normal, then the leak is likely to be in the ventilator or in the tubing. If the resistance is markedly reduced, the cuff leak is likely. That is what is possible. So disconnect the patient from the ventilator, and if the leak persists, then it is probably an endotracheal or a tracheostomy tube at fault. Check the cuff. If the leak still persists, it may be positional. So one can reposition the tube and then proceed with the ventilation. If nothing helps, then change the airway. I think that is probably the best way to approach the problem of leak. However, check the tubings all through and make sure that the connections are appropriate and right up to the ventilator. I think that is how we would approach a case of leak in a patient on ventilator.
So I think bottom line is that you start searching for the cause of the leak from the patient to the ventilator, from the tubing to the circuit, the ET tube. Is there a cuff leak? There's all these things that you need to look into and very, very carefully look into. Another concept that evolves from, when you're ventilating a patient is that of auto PEEP. You give certain degree of PEEP, but the patient is developing auto PEEP inside. So I'd like to ask Dr. Srima if she could actually highlight a little more and dwell upon this auto PEEP concept and how is it calculated?
So, as we already know, there are two types of PEEPs. One is the PEEP which we apply, which is called the extrinsic PEEP. The other PEEP is the one which is happening because of some other problems inside. So that is the intrinsic PEEP. It's also called as auto PEEP. So what happens is normally if the lung is not getting enough time to empty out, so there is not enough time for proper deflation to occur, then that results in some amount of air getting trapped inside the lung, and this causes a positive pressure. So this is more common in obstructive airway diseases, in COPD and asthma, where we are basically concerned about increased airway resistance, which results in air trapping. So it's also called as gas trapping, air trapping, dynamic hyperinflation. So all these things refer to auto PEEP. So how do we know whether auto PEEP is there or not? So if a patient is totally passive on a ventilator, then we can use something called as an expiratory pause. So what we do basically is different ventilators have different setups of giving an expiratory pause. So what happens is when we do an expiratory pause of about 3 seconds, 3 to 5 seconds generally, so what happens is the pressure equilibrates inside with the and then we get a measure of the total PEEP. From that we subtract whatever is the extrinsic PEEP, and then we get what is the intrinsic PEEP. Now, if a patient is fighting the ventilator, patient is tachypneic, in such a scenario, your expiratory pause is not going to work. So because the patient is going to trigger the ventilator, in that case, to measure, to know whether auto PEEP is there or not, you just have to look at the flow waveform. Dr. Bhajan already showed us the expiratory waveform, flow waveform basically. So the expiratory flow is below the baseline and it is supposed to return to zero before the start of the next breath. So if patients have auto PEEP, the expiratory flow doesn't totally return to the baseline. It goes down and then it immediately goes on to the next breath. So this is how we can, find out whether auto PEEP is there or not. So I
Right.
think
I
that
think that is
is
very important again. That, you look at the graphic and you see that the flow is not coming back to the baseline. That means there is some degree of air that the patient is retaining. And the complication of that would be stacking of air inside the lungs, resulting into dynamic hyperinflation, and then the consequences of that. So, Dr. Neeraj, how do you really handle these patients who are developing auto PEEP? What do you do with the auto PEEP so that it doesn't harm the patient?
Yeah, the auto PEEP, which is variably known as intrinsic or inadvertent PEEP or the occult PEEP, it is basically because of or associated with excessive uh, pressure support ventilation, significant airflow obstruction, high frequency, say more than 20 per minute, equal or inverse IE ratio, or there is history of air trapping in the past. So these are important associated parameters which result into auto PEEP. So we have to look for all these parameters if there is any evidence of auto PEEP. Actually, the measurement of auto PEEP is with pressure time waveform, which was very well shown in the presentation. Otherwise, occluding the expiratory port just before the next inspiration, we can measure the auto PEEP. If we have a look at the patient's presentation, it increases the work of breathing, basically. So we can identify that there is auto PEEP generating. We can reduce auto PEEP, or we can tackle these patients by reducing either tidal volume or reducing the frequency during pressure support ventilation, which should be less than 20. Or we can prolong the expiratory time, reduce air trapping by the use of optimum bronchodilator therapy. We know that auto PEEP is usually associated with complications like barotrauma or reduced venous return or hemodynamic disturbances, renal disturbances, etc. So auto PEEP should be properly identified either by the pressure time waveform or by occluding the expiratory port just before the next inspiration, and it should be properly taken care of by having a look at the tidal volume or the frequency during pressure support ventilation.
Yeah, very good. I think another basic thing is that if the dynamic hyperinflation is causing too much of a problem, like almost going into an impending pneumothorax or resulting in a hypotension or a shock kind of a state, I think best is to just disconnect the patient from the ventilator for a few seconds and let the patient exhale out. It's like a balloon, which you're just allowing to deflate so that there's no further dynamic hyperinflation. Also, I think auto PEEP gives you the advantage of calculating how much PEEP you would want to give to your patient. Giving about 80% of the PEEP, of the auto PEEP, helps negate the auto PEEP. So you give the extrinsic PEEP 80% of the intrinsic PEEP that will overcome the damage of the intrinsic PEEP then. So that is something that you need.
That is a therapeutic utility of auto PEEP. Yes.
Yeah, exactly. So auto PEEP is something that you would calculate when the patient is in. Dr. Seema, what did you say? Inspiratory hold or expiratory hold? It's always very confusing.
so auto PEEP is to calculate it, it is an expiratory pause we need.
Now there is something that you use the inspiratory hold for. So Dr. Komal, could you tell us about the inspiratory hold? What do you actually calculate and what is the relevance of that?
Okay, so this is, I think you are asking about the plateau pressure. So plateau pressure is, it is basically the static pressure that alveoli and the small airways are exposed to during mechanical ventilation. So in simple terms, it is the pressure which is required to hold certain amount of volume. It is directly related to the compliance of the lung. So, and how to measure it? So at the end of the peak inspiration, we have to perform the inspiratory hold for around 0.5 to 1 second. And there we can measure the plateau pressure.
Right, perfect. But the patient needs to be fully paralyzed and sedated for it. That is like a basic requirement.
Yes.
Otherwise, you never get the exact plateau pressure. Plateau pressure has a lot of role to play. Earlier for ARDS, you used to have the plateau pressure targeted that it can't go beyond 30. Now we have the
Yes.
driving pressure. So let me come back to Dr. Kushra, who was talking about the driving pressure in his talk. That what are the causes of increased plateau pressure and how to approach it, Kushra? How do we really manage it? There are patients who keep developing increased plateau pressures and becoming difficult to ventilate.
Thanks, Vivek. So Komal rightly said that plateau pressure is basically the distending pressure, how much volume can be given for a certain amount of pressure. So it is always measured in the end inspiratory, but as you rightly pointed out, we cannot really keep doing this, or nor can we paralyze our patients, neuromuscular blockage agents all the time. So basically, high plateau pressure is inversely proportional to the compliance. So lower the compliance, higher the pressure. The common causes would start from the time you intubate the patient. So once you've intubated and you've probably gone into the right bronchus, you've caused a collapse on the other side. So it becomes a smaller lung or a baby lung. And therefore, that can really lead to a high plateau pressure. Or it could be even a pneumothorax which has suddenly come up, or a collapse, or a flash pulmonary edema, or even ARDS, where we always measure the plateau pressure, as you rightly said. Or sometimes even an obese patient with abdominal compartment syndrome. Or if you have a patient with trauma, even lung contusion can lead to this. So basically, parenchymal problems are going to lead to decrease in the compliance, make available lesser part of the lung to be aerated and ventilated, and that leads to a higher pressure in the plateau because it is a distending pressure. So you rightly said we are talking about plateau pressure. So earlier it was tidal volume 6 mils per kg for ARDS, and we are talking of plateau pressures of less than 30. But now PEEP is playing a very important role, and driving pressure is nothing but this plateau pressure minus the PEEP. So you need to keep this below 15. So there are these numbers which you usually cannot get in a very bad ARDS. And therefore, finally, you need to prone these patients. There is something even newer than driving pressure, which is called a stress index. I skipped that. It basically also has one more parameter called the mechanical power. A bit complicated. I don't use it at the bedside, but I think in the next few years, we will be talking more about mechanical pressure, which is taking respiratory rate into account. So it is 4 times the volume into respiratory rate. So higher the respiratory rate of the patient or set on the ventilator, more the shearing forces and more the damage. So I think ventilating an ARDS would look into plateau pressures, tidal volumes, not so much the peak pressures, and also the driving pressures and the mechanical power, if you may.
Yeah, absolutely correct. So, Dr. Tampi, now you have a patient who was doing absolutely well, and there's a sudden deterioration in his clinical condition. So, how would you approach this patient and diagnose what has happened to the patient? Can you please unmute yourself, Ji?
Sorry, that's a common occurrence, and we do see it often, and one has to be aware. One of the commonest things is the obstruction to the endotracheal tube or to the tracheostomy tube. And one must exclude the presence of secretions in the airway and get rid of them. If we can, try and use the catheter to be introduced into the airway and switch the patient over in case you can't, and to manual ventilation. And here, notably the plateau pressure will be normal, but the peak pressure would be very high. So in this case, it's better to change the tube many times. The other possibility is that you could have severe bronchospasm, which has come in. Now, obviously, by auscultating the patient, one can, diagnose the presence of wheeze and immediately suck out the secretions or nebulize the patient with bronchodilators, and that could help. Another common thing which Dr. Vajan has just referred to is the more the decreased compliance of the lung and the higher the pressure. So here again, pneumothorax is a very common thing which we see due to barotrauma. And the other thing is, as he mentioned, atelectasis and flash pulmonary edema and a large consolidation. All these can also, can be diagnosed easily by auscultation, percussion, and maybe a bedside chest X-ray can be done. And once having done that, you can treat them appropriately with an IPD or chest secretions of diuretics, etc., for pulmonary edema. As far as the last common cause that we see is the asynchrony, patient ventilator asynchrony, which clashes over the ventilator. And we have discussed in detail what are the causes of asynchrony. And once we identify them, we should go ahead and correct the patient or the ventilator and the settings and reset the alarms, etc., so that we have smooth ventilation thereafter.
So basically what you're saying is that you need a holistic approach towards the patient. It could be anything wrong from the ventilator to the tubing circuit to the patient himself or herself. The lungs could have been affected. There could have been a cardiac involvement, pulmonary embolism, MI. So many things could have happened. So you just can't turn a blind eye to a patient who's suddenly deteriorated. That is the time where you need to be in action. And one of the common things that you encounter when the patient is coughing or when the patient is distressed is a high peak airway pressure alarm. Dr. Srima, could you tell us a little more about the high peak airway pressure alarm and the various causes and how you would manage it?
Yeah, so peak pressure alarm is one of the most common alarms which we see bedside. So most common cause is the patient coughs on the ventilator and it just alarms for a second and then goes away. So that is the most benign cause of a high peak pressure alarm, but most of the cases it is more than that. So to find out about the causes of a high peak pressure alarm, so if a patient is passive on the ventilator and paralyzed, then what we can do is find out the plateau pressure. We just give an end inspiratory pause, check what the plateau pressure is. So like we have already discussed, the peak airway pressure is, there are two components to it. One is the plateau and the other is the resistance. So anything which causes increased resistance, so there will be a normal plateau pressure with a high peak pressure. If there is something wrong with the compliance, then there will be both higher plateau pressure as well as a high peak pressure. So high resistance is what we are mainly concerned about. Like just now we have already discussed a patient who is acutely deteriorating in which there is a high peak pressure alarm. If it's a very critical situation, patient is desaturating, then the most common cause is a blockage. So we should immediately disconnect the ventilator, pass a suction catheter and make sure that the tube is not blocked, because that is the most common cause. But if the patient is sort of okay and we have time, then we do a pause if the patient is passive and find out what exactly is the reason, and then check for anything which can increase the resistance. If it is a resistance problem, that is any bronchospasm, endobronchial intubation, blocks in the tube, and again the HME filter getting blocked or your expiratory filter getting blocked, all these can also cause some high peak pressure alarms as well. So important thing is that a very important thing is that if the ventilator is alarming high peak pressure, what happens is that most of the ventilators will cut your ventilation tidal volume at that point. So most of the time, if your pressure is exceeding that, like a set limit, if you have set a high peak pressure alarm limit of 40, and if it's crossing 40, the patient doesn't get ventilated at all. So it is something which you have to see immediately, because the patient can go into a total apnea because none of the breath is getting delivered. It just goes 30 ml, the alarm goes, and then the breath cuts off. So that is one thing which is very important, that we have to take care of it immediately.
Right. So basically, it could be an increase in the airway resistance or a decrease in the compliance of the lungs that could result in a high pressure alarm. And also sometimes, if nothing else, the patient may just be biting the tube and causing the airway pressures to be going up. So you need to put in a blocker there, the bite block.
Bite block as well.
Sedate the patient. Ventilator tubing could be kinked. So those are the things that are very, very essential. So as I've been repeatedly saying, you start your survey right from the ventilator to the circuit to the patient. That is the algorithm. And again, in the patient also, it should be from the airways to the lung parenchyma to the vascular pathology or a pleural pathology. All these things need to be taken into consideration for all these issues there. So from a high pressure alarm to a low pressure alarm, Dr. Neeraj, what would you want to talk about the low pressure alarm?
Yes, there is actually a minimum pressure set in the ventilator circuit during each inspiratory cycle. Alarms are usually triggered when the pressure is below that set low pressure limit. So simultaneously, whenever there is low pressure alarm, usually there are low volume alarm also, because they go simultaneously. They are also triggered. So there are actually 4 areas where the low pressure alarm can be triggered, and the commonest being the loss of circuit pressure. The circuit pressure can be lost because of either disconnection, or there is loose connection, or there is air leak. Among uncommon causes are loss of system pressure. For example, there is power failure, as we already discussed. There is gas disconnection, or there is air compressor failure. Then, if there is premature termination of inspiration, for example, the inspiratory time is less, excessive expiratory time is there, or there is excessive peak flow, then again there may be a low pressure alarm triggered. So these are some of the common causes of triggering of low pressure alarm. Along with this, there may be inappropriate ventilatory setting, which can be a blunder. So the low pressure limit, when it exceeds the peak inspiratory pressure, there may be a low pressure alarm. Or when the tidal volume, it limits limit the exceeds the tidal volume, then there can be low pressure alarm. So these are certain conditions when low pressure alarm can be triggered.
Right. So Komal, coming on to from alarms ringing in the ICU to an alarm which rings on the monitor when the BP starts to drop suddenly.
Yes.
So how do you approach a patient who's on the ventilator and has now suddenly developed a drop in his blood pressure? And the monitor is constantly going blim, 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 blim. So what do you do?
So this is a very common problem in a ventilated patient. So most common cause for the hypotension is obviously the decreased cardiac output. And it could be secondary to the decreased venous return. So when we are giving positive pressure ventilation, there is increase in intrathoracic pressure, which further gives rise to decrease in the pressure gradient. And hence the venous return decreases. So one reason is this. And second is when we are giving the alveoli are filled with the pressure, there is increase in the pulmonary vascular resistance also. So then there is decrease in the right ventricular output as well. So these are the causes for decrease in cardiac output, which will lead to hypotension. But when we are talking about the sudden drop in hypotension, we have to look at the complications related to ventilation, maybe something like barotrauma or cardiac tamponade or intrapulmonary hemorrhage, or some complication we are dealing with like sepsis, autopeep development. All these things can give rise to hypotension.
Right. Very, very important. So how do you usually manage such a patient who's developed hypertension?
So we have to manage those complications if we find out what are the causes for that hypotension. If it is due to decrease in cardiac output, we have to give the volume, and otherwise we have to manage the complications first. And as mentioned earlier, if there is autopeep development, we have to just disconnect the ventilator for a few seconds. And previously we used to do the compression of lung, but then we just disconnect the ventilator and it should be fine. And we have to give proper tidal volume and PEEP, of course. We have to manage the settings.
So, Dr. Kushrao, another clinical condition that we encounter very often, especially in northern part of our country during this season, is the influenza H1N1 related pneumonia going into ARDS. And of course, we've all encountered the COVID related ARDS. So how do you manage a patient who continues to be hypoxic despite being on 100% oxygen? What is the checklist that you would want us to follow for these patients?
Yeah, so earlier this is very important, and thanks for asking this, Vivek. So we obviously are on 100% FiO2 on these patients, and now we really don't know what to do. So the next step immediately is to increase PEEP or not. Now, not all patients can respond well to PEEP, and the outcome may be poor with higher PEEP. So recently there has been a little talk about the phenotypes in ARDS, and they're dividing them into inflammatory versus hypoinflammatory. And it's the hyperinflammatory group which probably does better with higher PEEP. When I say higher PEEP, it could be 10 or even going up to 15. So you need to individualize and try to check on the patient with this high PEEP method. Sometimes, which is again controversial, is a recruitment maneuver. Many a times it can cause hypotension and cardiac arrest, and therefore it is not recommended. But sometimes very carefully with arterial lines in place and giving adequate fluid, you might want to do a recruitment maneuver for 30 seconds with 30 PEEP and see whether it is recruitable or not. And COVID has taught us and again brought in one technique, and that is prone ventilation, and which after the Proseva trial is definitely being used. But in COVID, we went left, right, center, and upside down. So we did prone for every patient, even starting without the ventilator, etc. So definitely, if the FiO2 is 100, the PEEP is at its maximum, and still the patient's PF ratio is less than 50, then I would immediately prone the patient, or even earlier than that I would. I might sometimes use neuromuscular blocking agents, and now there is a resurgence of data that it could be helpful rather than harmful, and I would paralyze these patients at least till the oxygenation improves. I might even do permissive hypercapnia and allow the CO2 to go up, trying to increase the inspiratory time and reduce the expiratory time in order to improve my transalveolar pressure. If none of this work, then I might use a mode which is an APRV mode. Again, I have not used it much, but that can be useful. And if nothing works, besides keeping the patient dry, I might even have to do an ECMO on this patient. So this is the entire gamut of a stepwise approach for severe hypoxia in an ERD.
So basically optimizing the PEEP, recruitment maneuvers, then your prone position ventilation, neuromuscular blockade, and of course the I inverse ratio ventilation. And if none of this works, then probably go on to ECMO. Absolutely, very well enlisted. So Dr. Rampi, how do you manage it? So on one hand, we have hypoxia, on the other, we have hypercarbia. There are times when patient is on the ventilator, and yet the carbon dioxide levels are not coming down. So how do you manage these patients really?
Ideally speaking, hypercapnia is in a patient of COPD is usually best treated with a non-invasive ventilator rather than an invasive ventilator for obvious reasons. However, in case we have this kind of patient who's a COPD patient who's intubated on a ventilator with refractory hypercapnia, one of the techniques is to increase the minute ventilation by increasing the rate. Now here you can't increase the tidal volume for obvious reasons. You probably land up with volutrauma and pneumothorax, etc. in a COPD patient. So you can increase the respiratory rate and thereby the minute ventilation, which would try to get the carbon dioxide down. Now, if that doesn't work, then probably in a situation like ARDS, you could use prone ventilation, but that's not recommended in COPD patients. There, you would probably have to resort to the APRV mode, which has been recommended, though it's not the primary mode of ventilation for COPD patients. But however, in refractory cases, people have used the APRV mode with a little pressure support because it helps improve the alveolar recruitment, and pressure support is added to reduce the hypercapnia in these patients. Of course, unlike hypoxia where you can put the patient on ECMO, here probably extracorporeal CO2 removal could be resorted to as a last resort.
Right. So Dr. Seema, coming on to the next concept of inadequate ventilation, what do you really mean by it, and how do you approach a patient where you feel there's an inadequate ventilation?
So ventilation, hypoventilation is, I think, do you mean to ask in cases of COPD where you have persistent hypercapnia? And so, yes, so there are two cases in which we have to deal with hypoventilation cases. One is our COPD exacerbation patients who have high CO2 levels, and the other is our obesity hypoventilation. So most of our OHS patients do quite well once we put them on the ventilator because their upper airway things are taken care of. But in case of COPD, we do have patients who have a persistent hypercapnia. As we already discussed, rather than optimizing the patient's factors, how do we increase ventilation? So minute ventilation is a function of respiratory rate and the tidal volume. So if we have to increase the ventilation, we have to increase both. Now, an important concept we have to understand here is that, like, if though it is a a multiplication of respiratory rate with the tidal volume, it's always better that we keep a higher tidal volume, because if you just keep 400 ml tidal volume and a 10 respiratory rate, we do have 4 liters of minute ventilation, but we have to understand that there is something called as a dead space. So if you reduce the tidal volume too much and increase the respiratory rate, even though the product may be the same, the amount of ventilation, the alveolar ventilation would be less because of the dead space. So thing is that just increasing the respiratory rate alone, if you have a very low tidal volume, even though number wise your ventilation would be looking good, it will not be giving you the alveolar ventilation because of the dead space loss. So basically, so if it is a volume control ventilation, you have direct control over both parameters. You can increase your respiratory rate as well as the tidal volume. But if you're using a pressure limited mode, like a pressure control ventilation, then obviously to increase the tidal volume, we need to increase the pressures, that is the inspiratory pressure control level above the PEEP. So that is how we achieve. And in a pressure support ventilation, obviously we increase the amount of pressure support. So that is how you indirectly control the tidal volumes. So yeah, I think that's what you meant.
So Dr. Neeraj, we've seen that there are so many pulmonary conditions that could be resulting in these ventilator alarms. So do you think if the X-ray is not available, or if X-ray is taking time, we could take the help of a bedside ultrasound for troubleshooting? Identifying the problem and then treating it accordingly. Dr. Neeraj, you're muted. I think we've lost the connection. Anyway, so we'll come back to that question later. So Dr. Komal, now, there are times where patients just accidentally extubate themselves.
Neeraj is back.
Neeraj is back? Okay.
Neeraj can, yeah.
Yeah, he's there.
Yeah. Am I audible?
I'm asking you on the role of ultrasound, bedside ultrasound, for the diagnosis of, the pulmonary conditions that could result in alarms ringing in the ICU.
Yeah. So as far as role of ultrasound is concerned in ICU, we can see that ultrasound can diagnose many of the things, although it is not gold standard, but it can diagnose or suggest many of the things, abnormalities, or even the success of weaning. So right from the pleural abnormalities, parenchymal abnormalities, diaphragmatic abnormalities, pulmonary thromboembolism, even echocardiography, we can have with the help of ultrasound. So there are different patterns which we can look forward for the pleural diseases or the parenchymal diseases, which can suggest that there is some abnormalities which can suggest us to alter the mechanical ventilation strategies. For example, if we have look at the A lines which are present bilaterally and there is pleural sliding present, we can it can suggest the presence of pulmonary edema, whether it is ARDS or cardiogenic pulmonary edema. Likewise, if there are bilateral B lines present along with pleural sliding, then again it can suggest presence of ARDS. Pulmonary thromboembolism can be diagnosed with the help of lung ultrasound, and of course, echocardiography can suggest the presence of ventricular failure, by right ventricular or biventricular failure. Similarly, the diaphragmatic excursion can be seen with the help of ultrasound, and they can suggest the presence of weakness of the diaphragm. Again, the pleural pathologies can be diagnosed with the help of ultrasound, whether there is pleural effusion or pneumothorax. They can be easily diagnosed in ICU with the help of ultrasound. As far as weaning is concerned, the presence of pulmonary B lines in an intercostal spaces, if there are 3 or more, then they can suggest that aeration of the lung is very poor and the possibility of failure of weaning is there. So there are certain suggestions, although not gold standard, they can suggest us that the ventilatory strategy should be continued, or it should be changed, or patient can be weaned or not.
Right. Thank you, Dr. Neeraj. So before I go on any further, I'd like to request all the audience sitting there that this is your opportunity to ask the questions from the stalwarts. So just post your question and you'll get your answer. I assure you that. Do not hesitate. This is the time to learn. Put in your questions into the chat box and we'll answer each and every question of yours this evening. So coming to Komal, Komal, there are times when patients just extubate themselves, self-extubation or accidental extubation. What do you think? Is it only because patient is restless and is pulling it out, or is it a nursing problem, or is it that there was probably a patient ventilator mismatch that resulted in it?
Sir, all together create the problem. So to start with, when the tube is not placed properly, it is not secured properly, rather, the cuff pressure is not maintained, the patient coughs violently, the patient is agitated or like in delirious, and the position of the patient, prone position, gives rise to accidental extubation so many times. So it is altogether what factors you mentioned. All of them play a major role in accidental extubation. And to diagnose it further, when it is just in front of our eyes, we can diagnose it. But sometimes what happens that patient has extubated and the tube is just above the vocal cord, but still in the mouth. That time we cannot find out that the patient has already extubated. At that time we have to look at the alarms. And if there are low pressure alarms or apnea alarms, then we have to again, as we have been telling this, that look at the circuit and the ventilator and the patient. So then we can make out that the patient has been extubated accidentally.
Vivek, can I make a small point?
Yeah, sure, please.
Yeah. So very well mentioned, Komal, but there was a study which said that 60% of the patients who did self-extubation, it was because of a delayed extubation. So sometimes the patient gets wiser than the doctor.
Takes his own decision.
Yeah. And this is a study, it's not made up. So yeah,
Yes,
we need to
definitely.
actually decide when to extubate,
Extubate the
when to wean the
patient.
patient
Yes.
on a daily basis.
Yes. Sometimes we joke on the rounds also that let the patient extubate themselves.
Not really. Yeah. Sorry.
So, Dr. Krishna, our last question of this evening, from my side at least, and then we'll take up the questions from the audience. That, I'm sure there would have been times when your resident doctor has called you up in the middle of the night saying, "Okay, boss, the alarms are ringing and I'm not able to figure out what is going wrong." Sometimes it's a low pressure alarm, sometimes high pressure alarm. I've adjusted everything possible, but it's just not happening. So, what is the advice that you usually give them on the phone then?
I'm now lucky enough to have a good 2-3 tier ICU staffing. So usually it would be missed by the juniors but picked up by others. But by and large, if there is an alarm which is low pressure or suggestive of a leak and they can't really figure it out, then I would ask them to ambu the patient. The problem with ambuing the patient is that you are at least saving the patients from turning blue and black and finally dying if you have not picked it up within seconds. But the problem is in ARDS, whenever you disconnect, you are de-recruiting all the alveoli. So we always keep an ambu bag with PEEP, 5 or 10 at least. So whenever we have to do that, we don't compromise on the atelectasis. Having said that, many a times at 2 or 3 in the night, if they cannot really identify the problem, I now use my AI technology and WhatsApp, and I tell them to go live and show me the entire settings and the graphics, and I try to troubleshoot it. Not only for ventilator graphics, but even hemodynamics, even IABPs in C2. So I get those calls and I might do it over the phone via WhatsApp. And finally, if I also don't know, then I'm not very sure what we could be doing. There may be some issue, so ventilator issue or patient issue, and it usually by and large will be sorted and we would find a cause.
Yeah, so basically the message that you want to give them is that immediately disconnect the ventilator, get the patient onto an ambu, put the ventilator, attach the ventilator to the test lung and see if the ventilator is functioning normally or not. So that is the first thing that you look at is there a ventilator malfunction or not? While you're ambuing the patient, you try and decipher if it is a patient-related problem. So maybe suctioning helps. An urgent X-ray may help. Checking the position of the tube, checking the pressure in the bulb. All those things may help. So these are just things which will help you save the situation and save the patient. These are basic things that we all must keep in mind, that whenever in doubt, immediately disconnect the patient and take the patient onto an ambu, and continuing the ambu till you've sorted the issue out. I mean, so many times it's happened that we've had to change the ventilator because the ventilator was not delivering the right amount of tidal volume or the respiratory rate for that matter. So let me now open up the questions from the audience, see what we have in store here. Just give me a minute. Yes. So we have Dr. Bhavyaja from Maharashtra, Mumbai, asking that what is the difference between inspiratory pause and expiratory pause? I think we've discussed that already, but Dr. Sima, since it's come as a question, would you want to just repeat that once?
All right. So, both are totally different. Only thing is that they have a word pause in both. So the uses are different. So basically, all these ventilatory maneuvers are useful if the patient is passive, that is, patient is sedated and paralyzed. If the patient has a lot of efforts on their own, these values do not help us that much. So inspiratory pause is given at the peak of inspiration, and that will help us get the plateau pressure. And also, that is basically when you have a high peak pressure, we can get to know whether it is because of the compliance issue or the resistance issue. So that is at the peak of inspiration, you pause the breath and you get the plateau pressure. Expiratory pause is when we stop the breath at the end of expiration. That is to measure the total PEEP. So that is when we are suspecting an O2 PEEP issue. In that case, you give an expiratory pause and find out what is the total PEEP. Subtract the amount of PEEP which you have applied from the total PEEP to get the O2 PEEP value. So the significance is if there is O2 PEEP, then that is dynamic hyperinflation. You have to take care of that. That is, like we already discussed, see whether there is any bronchospasm, treat any other causes of increased airway resistance. And for plateau pressure measurement, significance is in any ARDS ventilation, you need that for optimizing your ventilator settings. Like we have in guidelines to keep the plateau pressure less than 30. So we will be trending. So all these values are important when you check it every day. So you in a COPD patient, you would be checking for O2 PEEP when you're ventilating, like periodically. And in an ARDS patient, you would be trending the plateau pressure. You would know which direction the patient is moving. So it's important in a single time point as well as a trend, all these values.
So next question is from Dr. Bhavyaja, again from Maharashtra, asking us that how to deal with a patient on ventilator with a high peak airway pressure. So I think, again, Dr. Seema, you would answer that during your panel discussion. I think it is important to start searching from the tubing itself, whether the tubing is kinked, ET tube is blocked, is the patient biting the ET tube, and then going on to see if the ET tube cuff has herniated, if there's any endotracheal secretions which are blocking it. There are times where there are endobronchial plugs, mucus plugs, or even blood clots that could be blocking and causing an increase in the airway resistance and resulting in increased airway pressure. Then, of course, the bronchospasm in the airways, and then moving on to the lung parenchyma, where it could be because of a pneumothorax, pulmonary edema, a large pneumonia that might have developed. So these are all the things that you need to consider when you're talking about an increase in the pressure, high pressure airway alarm. Then we have Dr. Shehbaz asking us again from Mumbai. Lots of questions from Mumbai. Huh? Where are the rest of the people? Have they gone out to sleep already?
It's
They are
too cold in
again.
Delhi, so
I guess they're probably in their quilts by now.
Where is the city that never sleeps?
So they have a question called saying that what are the cause of low tidal volume ventilation in cause of low tidal volume in ventilated patient. So Dr. Neeraj, would you like to take that question?
Yes. So in a ventilated patient, there is if there is low tidal volume, it means either there is loss of some pressure in the circuit. So we have to look for the circuit first. Is there any loose connection, or there is disconnection, or there is any air leak? which may be even in the endotracheal tube. So this is one of the most common cause for low tidal volume. Otherwise, loss of system pressure can also be looked for. If there is gas disconnection or there is air compressor failure, then again the tidal volume delivered may be low. If there is inspiratory time too less for the tidal volume to be delivered, then again this may be a cause of low tidal volume. So these are certain important causes which should be looked for.
Right. Again, somebody's asked us that this is Dr. Sanket again from Maharashtra, that what is the solution for patient asynchrony? Dr. Seema?
Solution for asynchrony, there is no single solution. You have to identify what is the reason for asynchrony. Like we said, if it's a patient issue, if the patient is having a high ventilatory drive which is out of proportion to what we are managing, like if the patient is having pain, anxiety, fever, agitation, so you have to treat that. But most of the times what is the reason is our ventilator settings. So we have to see where the asynchrony is. If it's a trigger asynchrony, then we have to take care of it. If it's an ineffective trigger, most of the time it is because of auto PEEP. So there is no single answer to it. But I would like to emphasize that paralyzing the patient should be a last step. It should not be a first step to, because our point of mechanical ventilation is to finally liberate the patient out of the ventilator. So paralysis should not be a first step, unless it's a very emergency situation, and most of the time you would be able to solve issues if you give it some time and do not panic. So there is no single answer to manage asynchrony. You look at the patient. If it's very acute and you feel you do not have time, maybe a single shot of opioid and connecting the patient to the AMBU and giving high flow oxygen via the AMBU and taking care of the ventilator and seeing what is the issue to buy time, that is okay. But paralyzing the patient upfront is, it is.
Right. Perfect. So basically, you have to identify the cause and then treat it accordingly. Now we have a question from Dr. Shyami Saha. So he's finally woken up. This is from West Bengal, 24 North Parganas. That Dr. Dr. Bhajan, I would like to address this question to you, that how to identify a pneumothorax on a ventilator graph.
Yeah, so basically a pneumothorax would suddenly cause high peak pressures and also plateau pressures. Both would suddenly go up. And if you wait too long, the blood pressure will start dropping, because remember that a simple pneumothorax, if not picked up early enough, would lead to a tension pneumothorax on positive pressure ventilation. So we should be extremely vigilant about this, and we need to look at the graphics. What would happen is a sudden rise in the peak pressure, a sudden rise also in the plateau pressure, and the drop in the blood pressure. So you must auscultate, as Dr. Tampi said, look at the patient, not only the graphics. And as beautifully elicited by Dr. Neeraj, I would use a POCUS at this point, and I would try to diagnose a pneumothorax until the X-ray comes, because I will even try to drop the PEEP and see whether the oxygenation improves, because added ventilation, added PEEP is going to hypoventilate the patient, rise the CO2, and also cause severe hypoxia. So basically just peak pressures and low tidal volumes is what you will suddenly see.
Right, very important. So then we have a question from Dr. Tinithana Ansari from Manipur, Kerala, asking us about reverse triggering. Dr. Tampi, would you like to explain about reverse triggering?
I think I'll pass this question on to Dr. Khusro.
Yeah, so basically it's a form of asynchrony, and remember that there will be a trigger problem. So by and large, your trigger should be an ideal trigger is that trigger which is very sensitive, but not so sensitive that starts auto triggering. So we need to set a pressure trigger which would be -1. And as Vivek had mentioned, when there is auto PEEP, when you want to wean the patient, you keep an extrinsic PEEP of 80%, which is called as the waterfall phenomena, and it helps to trigger. So by and large, if auto PEEP has increased, then the patient would have a trigger problem. So that trigger problem could be double triggering or auto triggering or reverse triggering. And this really don't have to differentiate, but try and find out what is the cause of the asynchrony that is happening.
So just in continuation with that, there's also a question from Dr. Gopi Krishna from Telangana that what about double triggering and flow starvation?
Yeah, so it's the same thing. The flows, there are three types of asynchronies. One is the trigger. So when pressure doesn't work, then you might do a flow trigger. And there could be a flow starvation, which you would see as a scoop in the volume loops. And that would tell you that there is flow starvation. The main problem here is the trigger, even in that, and the rise time. So the rise time needs to be adequate. If the patient is trying to take a deep breath and the rise time is very slow and the tidal volume is being delivered extremely slow, then you might want to increase the inspiratory rise time and inspiratory, So by doing that, the scooping of the graph and the flow starvation will be reduced.
Shall I just put in a point, sir?
Yeah, sure, please do.
So, sir, the question about reverse triggering, I would just like to add one point. So, the most of the trigger asynchronies happen in patients who have effort. So, reverse trigger is the asynchrony which happens in deeply sedated patients. So, what happens is it's called as reverse trigger because it's not a trigger by the patient. So, what happens is the first breath it appears like a double trigger on a ventilator, but the difference is that in a reverse trigger, it is when the ventilator pressurizes the patient's lung, that causes a reflex diaphragmatic contraction and triggers the next breath. So in case of a double trigger, both will be patient triggered. But if it's a reverse trigger breath, the first will be a machine triggered breath followed by something which looks like a diaphragmatic contraction. So it's not actually the patient triggering, it is a reflex contraction in response to the inflation by the ventilator. So this happens in deeply sedated patients or in patients with neurological issues. And the way to tackle it is to reduce your sedation. And if you paralyze it, obviously it will go because it's basically the diaphragm contracting in response to the deflation. It's like a stretch reflex happening.
Right. So Dr. Vishal wants to know about guidelines on weaning. So I guess, Vishal, this is a topic in itself, and we should be discussing probably in the next webinar that happens as a part of these ICU series of webinars. We have a question from Dr. Binu Raj, which talks about expiratory tidal volume was too low as alarm for a ventilator is seen in which condition. So we've already discussed this about the expiratory tidal volume going low. Then we have Dr. Rida from Maharashtra, Mumbai, where she wants to ask us how to deal with patient on ventilator with high peak pressure. We've already discussed this, that you identify the cause and treat it. Then we have a question from Dr. Satish from Kerala regarding I/E ratio. Is it standard to keep 1:3 for obstructive airway, or are we liberal to change it as per graphs? Dr. Kushra?
Yeah, so basically you need to see how much auto PEEP, how much bronchospasm the patient has, and you would need to even drop it to 1:4 or 1:5 at times. Never keep a pause pressure whenever you are using a volume control. So there should be no pause. There should be just inspiration and expiration. And I'll just very quickly tell a story on this auto PEEP thing. There was a patient who had severe auto PEEP, an asthmatic young person who was intubated. And during intubation, the patient was umbued pretty heavily and auto PEEP developed. Patient developed a CPR situation because of cardiac arrest. And this was all because of the auto PEEP causing almost no flow into the heart and out of the heart. And the patient was declared dead. I don't know how far this is true. So the patient was declared dead and the rounds continued in the ICU. And within about, say, 3 or 4 minutes, when the patient sister had actually disconnected the ventilator, the graph on the arterial line came back and they thought it was a ghost in the ICU. So very rightly said, as Dr. Vivek mentioned earlier, that you might have to disconnect the ventilator. This is a teaching kind of point, that do not ventilate them aggressively whenever you ventilate an asthmatic or a very bad COPD. There is a slight difference in auto PEEP and dynamic hyperinflation, but by and large, you drop your respiratory rate to almost 4 or 6, not even 10 or 20. And then once the patient settles down, the BP settles down, then you might increase it. And don't be in a rush to bring the carbon dioxide down.
Dr. Krishna, on a lighter note, I think it's also reflecting that, reiterating the fact that patients sometimes take their own decisions.
Didn't want to die. Yeah.
Self-extubation, you disconnected and the patient's heart started pumping on its own.
Yeah.
So I guess you have to give it off to the patients also sometimes.
Also, yeah.
Like, okay,
Listen to
boy,
them.
it's your time now. We've done our best. Okay, so we have Dr. Ajay asking us that in case of hypotension, to reduce the auto PEEP, disconnect the ventilator, we said, but how frequently would you do that, Komal? I mean, I think what he's wanting to ask is that you've done that once. Would you do that another time, yet another time?
So
Waiting for
once
it?
we, yeah, for once we do that, and we check the settings first, that why the autopip is being generated, and if there is bronchospasm or what is wrong with the patient, and then we don't need to do it again and again.
Right.
Absolutely.
You just do it once or twice and see. Otherwise, you have to basically correct the underlying pathology. By this, you're not actually correcting the pathology. You're just buying some time from the patient. That's it. Dr. Maria from Pune wants to know that will increasing the respiratory rate help wash out the carbon dioxide, Dr. Tampi?
Yeah, in fact, that's what we discussed, refractory hypothermia in a patient of COPD. Definitely, the increasing the respiratory rate would increase the minute ventilation and help to wash out the CO2 in these patients. So that is what we always attempt first before we try any other modes of ventilation, as I mentioned.
Right. Then we have question from Dr. Vinod Tana from Maharashtra again, that if patient is hypoxic on ventilator, what all will you do? We've already discussed that in our discussion. So probably you could, subsequently log on to the YouTube of this panel discussion and see it again, because we have a lot of questions to answer. That is why I'm now started to skip and we have very limited time left with us. Now, Dr. Jignasha wants to know that how to identify presence of bronchial secretions from a ventilator graph, Dr. Bhajan. Very
So
simple.
secretions will look like a sawtooth, and therefore you need to do the suctioning. But again, in ARDS, every time that you do a suctioning, you are actually de-recruiting the alveoli. So I would say refrain from that, even if you see the graphics. Unless ventilation is a problem, do not keep on suctioning just because you see some variations in the graph.
So basically, you'll see those fluttering kind of waves in the
sawtooth kind.
Sawtooth, yes. Dr. Prutha from Rajkot wants to know that what is permissive hypercapnia and what range of pH and PCO2 is acceptable. Is Dr. Neeraj there with us? I think he's dropped out. So Komal, would you like to take this question? Permissive hypercapnia. What pH, what PCO2 is acceptable? And when to give IV bicarbs?
You're muted. Yeah.
Yeah, pH of more than 7.25 and PCO2 could be around 55 to 65. I am not sure about it, but pH should be around 7.25. I think I'm right.
Actually, almost 70 to 80 PCO2 also, but not more than that, because then it could cause certain cerebral issues. So you want to restrict it to that level.
Okay.
Dr. Jugal from Gujarat, how to decide on recruitment measures of PEEP in ARDS? So I think we've discussed that already, that you just give them a trial of recruitment measures and see whether the patient is really responding to it. As Dr. Kushra also said, there are basically these ARDS phenotypes now that will determine whether the patient will really benefit with all the recruitment measures or not. But the only idea is to give them an extra PEEP for some time to see whether you're able to recruit the alveoli again or not. Dr. Hina wants to know what should be monitored while increasing the PEEP in ARDS patients. Again, basically, you should be worried about the barotrauma that you may be causing in these patients. Barotrauma as well as hemodynamic compromise. If the PEEP is too much, there could be hypotension also that could result in these patients, because that wouldn't allow the venous return to happen. Dr. Manan wants to know that persistently high peak airway pressures are suggestive of what and how to manage this. Again, you have to look at the cause of the high airway pressures. It could be anything from lung parenchyma to airway problem to a tube-related problem, circuit-related, or the ventilator problem. Dr. Kapil, is wanting to ask that what are the issues in patients who develop a persistent air leak on ventilator and what settings are recommended? Dr. Tampi, so basically, I think he's wanted to know about the BPF that the patients develop while on ventilator and how to manage these patients while they are on the ventilator.
Yeah, I think BPF is a difficult problem to manage on any positive pressure ventilation, and we all know that. So there is no ideal solution to that. But however, we would try to reduce the PEEP as much as possible in these patients. I think that should be the first approach, and then hope like hell that the BPF closes while you're, reduce the PEEP to the basic minimum and continue ventilation and try to get him off ventilator as quickly as possible, so that you can approach the repair of the BPF either intrabronchially or by VATs. That should be the approach.
Absolutely correct. So basically, it has to be a low PEEP ventilation, low tidal volume, low PEEP ventilation, so that there's no further barotrauma than to what has already happened to the patient. And of course, endobronchial therapies in this situation can really work. We've been doing that in our patients where we do a bronchoscopy and with the help of a balloon try and identify which segment or lobe is the patient leaking from and then block it with certain endobronchial blockers. And we've had a fair bit of good results with it. Dr. Chaya from Mumbai, that what are the ventilator adjustments recommended when doing bronchoscopy in a mechanically ventilated patient? Dr. Srima, would you like to take this question?
Okay, so adjustments for a bronchoscopy in a mechanically ventilated patient. So mostly I suspect it's going to be a diagnostic bronchoscopy in which you would want to do a BAL or to clear a mucus plug. So generally we would avoid doing a lung biopsy in a patient who's on positive pressure ventilation unless absolutely indicated. So in such cases, basically we would obviously give patient sedation and analgesia, and I would prefer to give a single shot of a short-acting paralytic as well. So that is the patient preparation, and always make sure that you have a bite block. Even if your patient is paralyzed, you do not want your bronchoscope to be damaged because of a patient bite or whatever. So a bite block is absolutely necessary. On the ventilator, you would increase the FiO2 to the maximum, then 100%. You would pre-oxygenate, like before doing the procedure, 5 minutes prior, you would put the patient on 100% FiO2. Then another thing to take care is your peak pressure alarms. The moment you introduce your bronchoscope, your peak pressure alarms are going to go up. So you would want to, set a higher limit. And reduce the number of reduce the respiratory rate and the PEEP also, because once your bronchoscope is in, it is going to provide some amount of PEEP. So added on extrinsic PEEP again, there might cause some barotrauma, but we generally don't go down to zero. Especially if a patient is an ARDS patient, we wouldn't keep zero PEEP there, obviously. So we would come down. If a patient is on 10 to 12 of PEEP, maybe you keep 8 to 10, reduce it a little bit when you're doing the scopy. And of course, even though doing a scopy would be easy on an ICU patient, you should be expecting all sorts of complications, arrhythmias. You should always have help on hand, and make sure that your duration of procedure is as short as possible. So you make sure that you have help on hand whenever doing, even though you would think that it's an easy procedure, that the tube is already in, you just have to go in, but your patient is physiologically very bad. So you have to, take care of that as well.
Right. Very good. So Dr. Sheena from West Bengal wants to know that if the patient develops a pneumothorax, then how to identify it? Well, we've discussed that already, Dr. Sheena. Dr. Chandra from Kolkata, then what is the relationship between ET tube, tracheostomy tube size and gas exchange in patients with borderline reserves such as COPD and ILD? I guess I'll put this question to Khushraw, who will be the best person to answer this.
So do not please decide your tube size depending upon the disease. Use a normal size of 8 to 8.5 for males and 7.5 to 8. We go a little higher. We use always 8 for women and 8.5 for men. The larger size would definitely help in reducing the increased airway pressures. And also, whenever you need a bronchoscopy, then you can easily pass that through. And if you can put a 7, you can always put an 8 or 8.5. So don't always keep a 7 tube. Only when there is obstruction and you can't intubate, you would do that. Many a times we had a terminology called physiological PEEP of 3 or 4, which was supposed to take care of all the resistance in the endotracheal tubes, because earlier we used to use size 6 and 7. So I would refrain from changing the size of my tube, and across the board we don't have anything less than 8 or 8.5 whilst intubating in my ICU.
Right. Now coming on to a theoretical question, Dr. Tampi, I'd like to ask you this. This is from Dr. Nikhil Raj, I think, who's facing a little identity crisis. He's not sure whether he's from Maharashtra or from Delhi, because at the top it says Maharashtra, at the bottom it says Delhi. He wants to know that what is the benefit of saturation bleak FiO2 ratio in ARDS?
Yeah, I think the new ARDS.
What I wanted to ask actually is, instead of PaO to FiO2 ratio, if you were to use
Yeah. So I think the new ARDS definitions address this issue, and it avoids doing an arterial blood gas frequently in these patients. So therefore, you can get a saturation on your monitor, and the FiO2 is something that you're setting yourself. So it's easy to grade the kind of ARDS that you have, mild, moderate, severe, exactly, and then pattern your management accordingly.
Right. So finally, the last question from Dr. Aniket from Rajasthan, Jaipur, to Dr. Komal, that how to manage a patient who's in severe ARDS with pneumomediastinum, as high PEEP might worsen the latter. So patient with ARDS with pneumomediastinum, something that we've seen in our COVID patients, and then at the same time requiring a high PEEP.
High PEEP.
What would you do?
So we manage the pneumomediastinum first, and I'm not sure about this.
Yeah, so basically, if there's a patient with pneumomediastinum, you have to see if there's any associated pneumothorax or not.
Yeah, so we manage that complication first, and
if it's large enough, and get a surgeon involved, put in up maybe a pigtail there and drain that. Ultimately, you have to titrate between the PEEP, the tidal volume, optimizing all that together. If not, then ECMO is the answer.
Yes.
So I guess it's just a jugglery of all these 4-5 things that you can do when the patient is on the ventilator. And you just have to choose there and then that what is best for your patient. The safest, the best option is what you would choose in this situation.
Absolutely.
So with that, I think we'll call this panel discussion to an end. We've actually crossed our upper limit of 10:30. Also, it's 10:32 already. And I think it may just be a record of sorts. And I'm sure that there were so many more questions that we would have had from the audience had we got some more time to, continue this. I'd like to thank Dr. Khushra for an excellent talk, excellent presentation, making so much sense out of all those graphics that we see on the ventilator. And sometimes, don't even know what is actually showing up. But you've actually literally enlightened us with all of that today. I'd like to thank Dr. Shrima, Dr. Tampi, Dr. Komal Shah, and Dr. Neeraj for enlightening us with a very, very interactive panel discussion and very to the point, precise answers to the questions that were put. And again, I'm sure they add on to our knowledge so much. Sometimes I feel that even if you learn 3-4 points from one webinar, that has been a successful webinar. Of course, you all have a basic level of knowledge by now. Even if you learn 3-4 new things and go back, it's an enlightenment in itself. So with those words, I'd like to thank ICS for giving us this opportunity to discuss a very complex topic. And I hope, and as a response that we've seen, that we've been able to, give some more insights into it and tried and answered most of the questions that were put up to us today. So with those words, I'd like to hand it over back to the administrators to close the session. And I think I can see Dr. Nene joining in now for her final words.
And before that, Vivek, you did a fantastic job getting all of us together, and the amazing questions and the way you've coordinated and orchestrated the entire thing is amazing. I
moderation,
always
Dr.
look up
Vivek.
to your lectures and the way you deliver panel discussions. Thank you, Vivek.
Thank you.
Thank you.
Hi everybody. I normally don't log in, but I'm
You
so
only log in at the
tempted. I
beginning and at
couldn't
the end.
You should,
stop my,
Amita.
no, I couldn't stop myself because we've had the highest number of logins today, 1673 logins, and 1673 people are still logged in. It's a huge record. Hats off to each of our faculty. I mean, fantastic talk today, Khushrao. I mean, like, I learned so much. I mean, Vivek, you were incredible. You were like completely captain of the ship. Amazing, amazing moderation. And oh my God, there's one more question that has just come in, but I'm not taking it. Okay, our panelists were just phenomenal. My very dear friend, Dr. Tampi, Dr. Neeraj Gupta, who's our own ICS gang, Dr. Sraima from Kerala, and Dr. Komal, a proud Guju, who I feel so proud about, who's now in Nasik. So, I mean, awesome, brilliant panelists, wonderful discussion. I have learned so much. Thank you so much, my esteemed Galaxial Star faculty, for this wonderful, wonderful performance.
Thank you, Amita, for
Thank
the
you so much,
opportunity.
Thank you so much.
Thank you.
Thank you, Dr. Amita,
Okay.
for giving us the
Last
opportunity.
question. It's a very tricky